In this video, we will be covering aortic stenosis. Aortic valve is the valve between the lower left heart chamber called the left ventricle and the body's main artery called the aorta is narrowed and it doesn't open completely. This narrowing is called a stenosis. Aortic valve stenosis is narrowing of the orifice between the left ventricle and the aorta. When the aortic valve opening is narrow, the heart must work harder to pump enough blood to the body. The obstruction to the aortic outflow places a pressure load on the left ventricle that results in hypertrophy and failure. Left atrial pressure increases, pulmonary vascular pressure increases, eventually the heart may become weak, which may eventually lead to right-sided heart failure. What causes aortic valve stenosis? Heart condition present at birth called a congenital heart defect. Some children are born with the aortic valve that has only 2 curves instead of the usual 3. If there are only 2 curves, it is called a bicuspid aortic valve. Rarely, an aortic valve may have 1 or 4 curves. In adults, the stenosis may involve congenital leaflet malformations or an abnormal number of leaflets, that is 1 or 2 rather than 3. The leaflets of the aortic valve may fuse. Next cause is calcium buildup on the valve called aortic valve calcification. Calcium is a mineral found in the blood. As blood moves over the aortic valve, calcium can collect on the valve. The calcium deposits may never cause any problems. Aortic valve stenosis that is related to increasing age and calcium deposits buildup usually doesn't cause symptoms until age 70 or 80. But in some people, particularly those with changes in the aortic valve at birth, calcium deposits might cause the valve to narrow at the younger age. Next cause is rheumatic fever. This complication of untreated strep throat can damage the heart valve. It may cause scar tissue to form on the aortic valve. Scar tissue can narrow the aortic valve opening. It also may make a rough surface on which calcium deposits can collect. Other inherited or chronic conditions can cause aortic valve stenosis are Paget's disease of the bone, kidney failure, and familial hypercholesterolemia. And also it can be caused by autoimmune or inflammatory diseases like lupus and rheumatoid arthritis. Some risk factors are long-term kidney diseases, diabetes, high cholesterol, high blood pressure, and radiation therapy to the chest. Now we will see the pathophysiology of aortic stenosis. When the left ventricle contracts, it forces blood through the valve into the aorta and subsequently to the rest of the body. When the left ventricle expands again, the aortic valve closes and prevents the blood in the aorta from flowing backward into the left ventricle. In aortic stenosis, the opening of the aortic valve becomes narrowed or constricted. The pathophysiology of degenerative aortic valve stenosis involves fibrotic and calcific remodeling of the valve characterized by excess collagen deposition and disorganization. Inflammation is thought to be involved in the early stages of pathogenesis of aortic stenosis, and it is associated risk factors are known to promote the deposition of LDL cholesterol and lipoprotein. It is a highly damaging substance into the aortic valve, causing significant damage and stenosis over time. The pathophysiology involves immune-mediated damage to the heart valve tissue following streptococcal infection, resulting in scarring, commissural fusion, and subsequent calcification. Subsequently, fibroblasts differentiate into osteoblast-like cells, which results in abnormal bone matrix deposition, leading to progressive valvular calcification and stenosis. There is a progressive narrowing of the valve orifice, usually over a period of several years to several decades. As a consequence of this stenosis, the left ventricle overcomes the obstruction to circulation by contracting more slowly but with greater energy than normal, forcibly squeezing the blood through the very small orifice. So, the left ventricle must generate a higher pressure with each contraction to effectively move blood forward into the aorta. The obstruction to left ventricle outflow increases pressure on the left ventricle, which results in thickening of the muscle wall. Initially, the left ventricle generates this increased pressure by thickening its muscular walls, that is called myocardial hypertrophy. The type of hypertrophy most commonly seen in aortic stenosis is known as concentric hypertrophy, in which the walls of the left ventricle are equally thickened. In the later stages, the left ventricle dilates, the wall thins, and the systolic function deteriorates, resulting in impaired ability to pump blood forward. When these compensatory mechanisms of the heart begin to fail, clinical signs and symptoms develop. Many patients with aortic stenosis are asymptomatic. After symptoms develop, patients usually first have exertional dyspnea caused by left ventricular failure. Other signs are dizziness and syncope because of reduced blood flow to the brain. Angina pectoris is a frequent symptom that results from the increased oxygen demands of the hypertrophied left ventricle, the decreased time in diastole for myocardial perfusion, and the decreased blood flow into the coronary arteries. Angina pain is like a squeezing, pressure, or discomfort and can extend to neck, jaw, arm, or abdomen. Blood pressure can be low but is usually normal. There may be a low pulse pressure because of diminished blood flow. Fatigue may be present which can disrupt normal activities. Patient may have heart palpitations, swelling in the feet, ankles, or lower legs. On physical examination, a loud, rough systolic murmur may be heard over the aortic area. The sound to listen for is a systolic recrescendo murmur, which may radiate into the carotid arteries and to the apex of the left ventricle. The murmur is low-pitched, rough, rasping, and vibrating. If the examiner rests a hand over the base of the heart, a vibration may be felt. The vibration is caused by turbulent blood flow across a narrower valve orifice. Evidence of left ventricular hypertrophy may be seen on 12-lead ECG and echocardiogram. Echocardiography is used to diagnose and monitor the progression of aortic stenosis. The test also can show if the heart muscle is weakened. A standard echocardiogram that is called transthoracic echocardiogram is done from outside the body. An ultrasound device moves over the skin of the chest above the heart. If more details are needed about the heart, a transesophageal echocardiography may be done. This type creates pictures of the heart from inside the body. The ultrasound device attaches to a tube that goes down the throat and into the esophagus. Electrocardiogram test records the electrical activity of the heart. It shows how the heart beats. A chest X-ray shows the condition of the heart and lungs. It can show if the heart is bigger than usual, which can occur in aortic valve stenosis. It also can tell if there is calcium buildup on the aortic valve. Next test is exercise test or stress test. These tests often involve walking on a treadmill or riding a stationary bike while the heart's activity is checked. Exercise tests show how the heart reacts to physical activity and whether valve disease symptoms happen during exercise. Next test is CT scan. This test uses several X-rays to create detailed images of the heart and heart valves. The test may be done to check the size of the aorta and look at the aortic valve more closely. A CT scan may be done to see how much calcium buildup is on the valve. It also can show how severe the aortic valve stenosis is. Next test is MRI scan. A cardiac MRI uses magnetic fields and radio waves to create detailed images of the heart. This test can show the size of the aorta. It may be used to learn how severe the aortic valve stenosis is. Next test is cardiac catheterization. This test is often used to diagnose aortic valve disease, but it may be done to see how severe aortic valve disease is or to diagnose the condition if other tests can't. In this test, a doctor places a thin, flexible tube into a blood vessel, usually in the groin area or arm, and guides it into the heart. Cardiac catheterization also may be used before aortic valve surgery to make sure the heart arteries are not blocked. Now, we will see the management. How can we treat the patient? Mild cases of aortic valve stenosis are treated with some medications. These may include blood thinners, diuretics, and other medicines to treat heart rhythm disorders, high blood pressure, or heart failure. Medications help with symptoms but can't keep stenosis from getting worse. Antibiotic prophylaxis to prevent endocarditis is essential for anyone with aortic stenosis. Definitive treatment for aortic stenosis is surgical replacement of the aortic valve. Patients who are symptomatic and are not surgical candidates may benefit from 1 or 2 balloon percutaneous valvuloplasty procedures. Now we will see the surgery and procedures for aortic valve stenosis. First one is balloon valvuloplasty. This treatment helps open a narrowed valve. It may be done in infants and children with aortic valve stenosis. In adults, the aortic valve tends to narrow again after the treatment. So it is usually done only if an adult is too sick for surgery or if an adult is waiting for a valve replacement. In balloon valvuloplasty, a doctor places a thin tube into a blood vessel in the arm or groin and guides it to the aortic valve. Once in place, a balloon on the tip of the tube is inflated. This makes the valve opening wider. Then the balloon is deflated. The tube and balloon are removed. Next procedure is aortic valve replacement. Aortic valve replacement is often needed to treat aortic valve stenosis. In aortic valve replacement, the surgeon takes out the damaged valve and replaces it with a mechanical valve or a valve made from cow, pig, or human heart tissue called biological valve. Sometimes the aortic valve is replaced with the person's own lung valve called the pulmonary valve. The pulmonary valve is replaced with a biological lung tissue valve from a deceased donor. This more complicated surgery is called the Ross procedure. Next procedure is a transcatheter aortic valve replacement. Transcatheter aortic valve replacement is a type of heart valve surgery. It is done to replace a narrowed aortic valve. A doctor inserts a flexible tube called a catheter into a blood vessel and guides it into the heart. A replacement valve made of cow or pig tissue goes through the tube to the specific area in the heart. A balloon on the catheter tip inflates to press the new valve into place. Some valves are self-expanding. Transcatheter aortic valve replacement may be an option if patients are at intermediate or high risk of complications from surgical aortic valve replacement. Next procedure is aortic valve repair. Surgeons may fix the aortic valve by separating valve flaps that are stuck together. However, valve repair is rarely used to treat aortic valve stenosis. Generally, aortic valve stenosis requires aortic valve replacement.